Hey, good afternoon, everyone. Welcome. Welcome to the Fellows meeting. GECCO is hosted by the Gastro Foundation in association with the Project ECHO from the University of New Mexico. The GECCO Fellows is run every Monday at 6:30. And at the end of this, the chat will be open for questions. Our presenter for today is Dr. Nishlin Naidoo. He's a colorectal fellow from Wits University, and he's going to be talking to us about an interesting case that he's seen recently. Please can I ask that if you have any questions, you can stick them in the chat, or you can put up your hand and we will have a look at them once he's finished talking, or if there are any pauses in the middle of his talk, we can ask him some questions and we'll take it from there. Nish, would you like to share your screen?
Yeah, sure, no problem, Daniel. See if this works. Let's try again. Okay. Daniel, can you see the screen?
Yep, I got it.
Okay, cool. Hi, good day, everyone. So I've got an interesting case that I would like to present. May I ask people a few questions just as we're going along? Just some thoughts on what they would do with this sort of case. But yeah, I just thought this might have been an interesting thing to present, as it's something I've recently seen in the ward, and this patient is still with us. Okay, so let's get into it. So look, we had a 30-year-old female, a young female that presented to us from home. She had a 1-week history of abdominal pain, distension, vomiting, and she had some additional complaints of some constitutional symptoms, mainly night sweats. She had been seen at a private GP with a main complaint of abdominal pain and night sweats, but not coughing, 2 weeks prior. And the GP, did a urine lamb test, which was positive. However, no x-rays or other blood work was done. This patient couldn't afford anything more, and she had gone back home as the pain seemed to have settled. She's a university graduate. She's got no previous surgical or medical history. She had been tested recently for HIV and she was unreactive, with no history of loss of weight or loss of appetite at this point. I just wanted to hear some thoughts as to how some of you would go about investigating this patient that presented to you like this. So the main complaint, is abdominal pain, distension, and vomiting, and some night sweats. What would be your concerns in a 30-year-old female with virgin abdomen with these sort of complaints? Gert, maybe you'd like to express your thoughts.
Thanks, Nisha. So, I mean, with the history like this, obviously we are thinking in terms of our differential diagnosis about some form of an obstruction, which obviously is not unlikely to be an adhesive obstruction. She's fairly young still. We still need to consider something like a midgut volvulus, malrotation with the midgut volvulus is a possibility. And with the abdominal distension, one wouldn't really think of a very proximal obstruction like a gastric outlet obstruction. However, the vomiting, I didn't get any history on that. Was the nature of the vomitus?
Initially, it looked like it was bilious vomiting, but then after that, she started vomiting food, and that progressed to what she thought was feculent vomiting.
Okay, all right. So more in keeping then with the more distal obstruction. Then we have to obviously consider inflammatory conditions that may give rise to this. So inflammatory bowel disease, more in keeping with Crohn's disease. The history is just way too short for that. But we know that Crohn's patients often have symptoms which are then really recognized long before they present. Then she could also have thinking with regards to the RVD. One also needs to think about possible neuroplastic causes. and lymphoma, especially with the night sweats, would be something considered. And then as you
So remember,
mentioned,
she's unreactive, Gert. It's
she
just that she had that positive urine lamb test. I don't know, maybe you can express some thought on that. I mean, is
so
that sensitive enough to diagnose TB? What do you think?
so I don't think it is. I think one needs a bit more objective evaluation, but I mean, certainly TB is, with the constitutional symptoms would be very high on the differential diagnosis as well.
Sure. So I agree with you fully with your thought process. So I'll tell you how we managed this patient initially after that. So in terms of a clinical examination, you know, she was generally a small stature. She was not emaciated. She had NG tube draining feculent content. She was distended. She wasn't peritonitic. She did have positive shifting dullness, however, so we were concerned about fluid in the abdomen. Her chest was otherwise clear and unremarkable. She wasn't tachycardic. She didn't look very toxic. It's just our main concern was obviously that feculent content coming from her nasogastric tube, that persistent distension and not passing any stool. And remember, she's got a virgin abdomen. So at this point, Gert, or let me ask someone else, James, would you jump straight into a laparotomy for this patient, or would you like to investigate the normal?
Yeah, I was going to say she has an indication for laparotomy here. So the question is, do you go straight to surgery or do you image first? I think in a virgin abdomen, you benefit, you get a lot of information from imaging her first, and seeing as she's not unstable, I think I'd probably go for an abdominal CT before theatre. I'm guessing that's what you guys did.
Yeah, so that's exactly what we did. Look, we had a bit of time, so we did our blood work. She had an elevated CRP. However, white cell count was 6, her HP was 11. She did have a microcytic anemia, despite that HP being 11 as well. Her platelet count was borderline, was 151, still normal, and a normal UNE. She had dilated loops of bowel. She had a CT abdomen that was done for her. And, you know, just from the images, it looked like she had a small bowel transition point, no obvious masses that we could see. And it looked like it was coming from the distal small bowel. We also reviewed this scan with our radiology department. She got some IV fluid and analgesia. But ultimately, look, we thought this was a small bowel obstruction. So with feculent content draining from a nasogastric tube. So our idea was then to take her to theatre. She was taken for a laparotomy. And this is what I found.
Sorry, Nish, in a virgin abdomen with a transition point, what are you expecting to find? You haven't shown a mass, you haven't shown anything else, you haven't mentioned anything else on the scan, but any other clues?
So sometimes in view of Crohn's disease, you may see some other changes. You may see some other fluid within the abdomen itself as well. There was no fatty stranding in and around the area. The appendix looked in itself quite normal, but apart from that, we didn't see anything else. Just what looked like a transition point on the distal small bowel. And you know, we reviewed this as a department, and we reviewed this with the radiology consultants as well. But I'm going to get to the update on the CT abdomen because our CT abdomen findings in retrospect were actually incorrect.
Oh, sure.
So, yeah. So look, we took her for a laparotomy. Our intraoperative findings were the following. So she had an obstructing small bowel mass starting from around 270 centimeters from the ligament of Treitz. This mass was essentially involving the sigmoid colon. She had quite a thickened mesentery overlying that small bowel area, and this mass, inflammatory mass, was attached to the anterior abdominal wall. It's about 1 liter of acidic fluid, which we tapped and we sent off for MCNS cytology and for SAG. She had no pus and no perforation of the small bowel. So we proceeded to do an en bloc resection of this obstructing mass. So we took out that segment of small bowel that was involved, the sigmoid colon that was involved as part of that small bowel mass, and part of that abdominal wall. She ended up with a double barrel ileostomy and end colostomy, and that distal rectal stump was stapled off. Look, she was quite nutritionally depleted. She had a starting albumin of around 26. So we elected not to anastomose her. Her bowel was actually quite distended intraoperatively as well, and that was the reason for doing the stomas. Any thoughts on what you might think could be the underlying pathology at this point, having looked at, look, the mesentery was just thickened, there was no fat creep, no obvious perforation of the bowel, and as I said, there was no contamination of anything. Any ideas in a 30-year-old what you might be concerned about? Her spleen looked otherwise well at the time of the operation, so it didn't look enlarged. Her liver looked okay as well, and the rest of her abdominal organs and viscera seem to be okay. Any thoughts?
So could you tell from your clinical findings, sorry, that whether this was inflammatory, or would it appear more neoplastic?
No, it seemed like more of an inflammatory mass, almost like a chronic phlegmon that might have been there from, like something you would see in appendicitis that had been sitting for a while, that had been treated with antibiotics that then developed into an inflammatory mass. It looked more like that. There was no fistula going into the sigmoid colon itself. It was just involving that area and adherently attached to it, and we couldn't separate it. So that was the reason for the en bloc resection. Any ideas of what you think might be the pathology?
Yeah, so I mean,
any other questions that you might have?
With that sort of history, the history is just a bit, a clinical history is a little bit short, but I mean, with inflammatory mass in the small bowel, you still have to think TB and Crohn's disease most likely. Other things, potentially something like actinomyces can give you this sort of picture as well. And yeah, I think that's really, in terms of inflammatory conditions, the main things to think about, in my view.
Yeah, so look, we had sent off that specimen, including that fluid, for everything, because at the time we didn't know what it was, whether it was some neoplastic change or whether it was a primarily inflammatory type of response. And I mean that the distal segment of small bowel was about 100 centimeters from the ligament of Treitz. And as I said, no mesenteric fat creep or anything, because my initial thoughts was this something like an early diverticular abscess that might have sealed itself off? Was this maybe Crohn's disease, or was it something else that we were missing that might have been infective pathology? So we did send it off and mentioned that in our histopathology report at the time. And proceeding, in the post-operative period, this patient seemed to have settled well in the ward. Stoma was functioning well. Our outputs were initially high. We did a repeat TB workup for her in view of that urine lamb, which was unremarkable. We tested her again for HIV, which proved to be unreactive. She then developed wound sepsis and sheet dehiscence on around day 7 post-surgery. Now, at this point, we had gone back and looked at the CT again. And we also had an updated report from the radiology consultants after they had their own private meeting. And what we had missed was that this patient had a portal vein thrombus. She had splenomegaly and features of non-cirrhotic portal hypertension. We did a relook for her, and this time I was there for that relook again. The spleen did in itself look a little bigger than what it did before. She had no hollow visceral issues, minimal pus contamination. The abdomen was closed and we left the skin open. And then on day 10, 3 days after that, I mean, she was placed on tazocin at this point for her sepsis. She developed a right hemiplegia with an expressive aphasia, and a CT brain was done for her. I mean, this is a 30-year-old female, given that, and she had a left MCA territory infarct, was M2 territory. So we did a young CVA workup for her, carotid Dopplers, echocardiogram, a full blood workup, and eventually an LP as well, which didn't reveal anything. We also repeated a septic workup. But at this point, we've got a patient that seems to have a hypocoagulable state. So she's got a portal vein thrombus. She's now developed an infarct in her brain. And, at this time, thoughts were like, was there an ischemic event in the small bowel or in the colon contributing to that intra-abdominal pathology at the time? And this is when we started to look more or closer at what might be the underlying pathology in the abdomen or presenting pathology. And we decided to do a workup for vasculitis at this point. Her report came back, which just showed morphological features in keeping with an inflammatory pseudotumor with perforation of small bowel and large bowel with a central abscess that was contained. And she had an associated small bowel adhesion and stricture formation with some fibrosis. There was no neoplasia, no AFP, no fungal or viral organisms grown in that specimen itself. So yeah, just in summary of what we've now got an inflammatory mass involving that small bowel colon, an ischemic stroke, and a portal vein thrombus, and as I said, a hypocoagulable state. So as part of that, we did an autoimmune screen, and we did a vasculitis or full vasculitis workup. Showed that a protein S level was low, which most likely contributed to that hypocoagulable state, with an ANA that was elevated. However, remaining autoimmune workup was pending. So our working diagnosis at the moment for this patient is that it might have been a mesenteric vasculitis secondary to some form of autoimmune pathology. And that's what she's currently having a workup completed for. At the moment, she's being anticoagulated. I did a G-scope for her today and did find esophageal varices. She had 2 columns of grade 1 esophageal varices, which we are managing conservatively. Our medical GI team, rheumatology department, are all involved, and we're all a bit stumped by her underlying pathology at the moment. So we're just awaiting our autoimmune workup at this point. So yeah, I just wanted to briefly touch on mesenteric vasculitis because it's something that we don't see commonly. What we do see more of is mesenteric, fulminant acute mesenteric ischemia, either occlusive or non-occlusive. Vasculitis predominantly or specifically is actually quite rare. And there's actually very limited literature on the epidemiology. And it depends on which part of the world you're in. So usually in Asia or in some of the Western world, Takayasu's and Kawasaki's is more prominent in terms of large vessel. But in our setting, the viral infections such as HPV might be more prominent, or retro disease. There are concepts known as lupus mesenteric vasculitis, which is quite a rare manifestation of lupus itself. Rheumatoid arthritis and IBD as well have been reported incidences of causing small vessel vasculitis in some of these patients, and polyarteritis nodosa. So yeah, as we know, vasculitis is either classified into large, medium, or small vessel, or you can call it variable size vessels. And there's a whole host of different causes that one would have to think about when working up these patients. So, you know, sometimes you forget these things, and it's important to have the physicians closely involved in the management of these patients, especially with the initial blood workup. So look, we did everything for her from ANA, ANCA, ACLA, repeated a HIV. We did a young stroke workup for her with an echocardiogram, CT angio, which didn't reveal much at this point, apart from that diminished protein S and that high ANA that she has. We're still awaiting some of the lupus screens and cardiolipin. Usually the clinical presentation of these patients with mesenteric vasculitis is very similar to chronic mesenteric ischemia. So they have that typical food fear. So they're anxious about eating food because they typically have excruciating pain after meals, which is not uncommon for them to have. They have abdominal distension, and they may or may not have PR bleeding. But one of the more typical features is the food fear, which seems to be more predominant in these patients with mesenteric vasculitis. And then they also have systemic manifestations of the underlying disease pathology. So they may not have symptoms that are just related in isolation to the bowel. They may have a flare-up of their SLE. They may have a flare-up of their rheumatoid arthritis, and so forth, depending on the underlying pathology. So it's important to look out for that in these patients when you do see them. The workup would be the same. So if you suspect that a patient has mesenteric ischemia, you know, you do your bloods, your CT angio. CT angio is contraindication. And MR angiography seems to be of value in the current state. And then you'd obviously need to exclude other causes of mesenteric ischemia, occlusive versus non-occlusive, mesenteric vein thrombosis, or aortic dissection. It's just unusual in this case that this patient actually presented to us with a bowel obstruction, which we found quite interesting. But the hypocoagulable state manifested later on in the form of that portal vein thrombosis that may have actually been there from the beginning and then just precipitated itself even on a second CT scan and that CVA that she had. The histopathology from the literature seems to be very non-specific. So they may have some fibrotic change, stricturing, venous embolism, and mucosal damage as well. But again, these findings are actually non-specific on the histopathology thing. So it's a whole host of things, but mainly a diagnosis of exclusion and an autoimmune screen that would need to be done as well. In terms of the hematology workup, I think that's also relevant to mention, such as a JAK2, which would also need to be done. Management is also very similar. So if you suspect these patients have mesenteric ischemia, you do the same operation you would for mesenteric ischemia. You'd resect the dead bowel if it's suspected, and you'd go back and relook early to determine if there's worsening ischemia. And you try and make the diagnosis early if possible. But we know that some of the autoimmune workup to try and get in these patients usually takes some time. So the safest thing to do is always to anticoagulate your patient in the early setting and then try and treat the underlying pathology. So if it's SLE or rheumatoid, you might consider steroids or biologics or antivirals if it's a viral infection once you've made that diagnosis. So yeah, so it is difficult to make the diagnosis of mesenteric vasculitis. It's hard, not a common thing to see in isolation. Usually, if there's ischemic events, you must exclude other common causes, as I said, non-occlusive or other occlusive causes of mesenteric ischemia. We employed an MDT approach. I mean, we got all our physicians and the surgical department, including the vascular surgeons involved in this case. And it's generally safe to anticoagulate. So if you're uncertain, rather anticoagulate these patients early on. Yeah, thank you. Hope that was interesting. Anybody have any questions?
Thanks a lot, Nishlin. Thanks. That was a great presentation. Can I maybe start out? There is a question in the chat, which I'll come to now. You mentioned that you scoped her and you found varices. And that you kind of glossed over one of the causes that can trigger this is hepatitis B. If you could look for that.
Yeah, sorry, we did do a full viral workup for her. So she had a hep screen done for her as well. And that's not mentioned in that. So yes, we did do a full hepatitis screen for her as well.
The usual CMVs and things like that, and TB you've kind of managed to rule out. So the next question is, on that histology, did they have any crypt abscesses?
No, so just a central abscess, but no mention of crypt abscesses, which we specifically looked for. We also
specifically said no crypt abscesses.
Yeah, we also did mention that to our histopathology department as well. We do have a histopathology meeting on Wednesday this week. So as I spoke to Karen earlier as well, once we've got a concrete diagnosis at the next colorectal presentation for GEOCO, I'd be interested to give some feedback on this case to see what the underlying pathology in this patient actually was.
Because one of the things, it is a bit of a way out there complication, but remember that Crohn's disease and UC are hypercoagulable states on their own without your proteinase deficiencies. So I mean, look to take out the cerebral artery is a bit of a big one, but you know, it's not an impossibility. There was a question in the chat about, have you considered Behçet's in this patient?
Yeah, I think that's part of the workup that we're still undergoing at the moment. So it is part of our list of differentials that we're trying to exclude. But just in view of the diminished protein S and the high ANA, we're working on that at the moment.
Okay, so are there any other questions out there? I think you stunned them into silence.
I hope that was interesting. Yeah.
Yes, it sounds like we'll hopefully have a diagnosis on this at the next colorectal session, which, if I understand correctly, is the 26th of October. Down then. Great. So we'll hear from you then.
Definitely. Yeah. Thanks, Daniel.
Oh, hang on. Well, there is a question from Pat. I think it was great that you did an anastomose. What held you back?
No, look, her starting albumin was 26. The bowel was extremely distended and dilated. So when she came in, she wasn't in the greatest, in terms of her hydration and her nutritional status. She wasn't looking great at all. And I think that partly contributed to it as well. So it was a whole host of things. One, the distended bowel. 2, a very low albumin, and 3, just the overall condition of the patient.
As an aside, and just to clarify for myself, how many stomas did you give her?
3. So essentially, she's got a double barrel ileostomy, and then that segment of colon is vented, has a mucus fistula, and the distal rectal stump is stapled off in some.
So I really do think that is the safest way to do this for the surgeons online, and there is nothing wrong with doing that. I think it's also very important to do what you've done with the colon, and that is to vent it distally, because there is about 10% of patients who have an incompetent ileocecal valve. But if you're going to close off distal bowel, you can expect to have a blowout and a septic patient within sort of a few days. So I think it is quite important to vent that distal bowel just as you've done.
Definitely.
Okay, and I think bringing out the proximal ileum as a double barrel is also very good.
Yeah.
And when you come to closer, you can reverse that one, or you can even reverse your Hartmann's first and then reverse the double barrel, depending on how she does.
Yeah. Once we've got a diagnosis on her and we've treated her. Definitely.
Okay. Why has mine disappeared? Here we go.
Let me stop sharing.
If there are no further questions, I think we're stuck with my presentation next. Mine's going to be a whole lot more simple than your presentation, Nish. Oh, there we go. Can everyone see? Nish, can you see it?
Yeah, can see it, Daniel.
Yeah. So this is a whole lot less scientific and a whole lot more didactic than what Nishlin has presented thus far. It is just something that people tend to do really badly. There's a little bit of data in here and quite a lot of experience. So I just wanted to share this with everyone today, particularly the colorectal surgeons and anyone working in GI. And particularly the take-home message on this talk is the most important part of it. So I thought we'd have a look at hemorrhoids, since it's something that people don't pay much attention to, and it's something that gets used and abused rather a lot. And that is to have a look at the etiology, the complications, and the management. And I'm going to set this out in a series of 11 questions, apologies. You guys don't need to answer them. I'll answer them for you as we go along. And the first question that I had was, do you have hemorrhoids? And I usually pose this question to the students when I give this talk, and invariably there's sort of a nervous giggle around the room, and 1 or 2 people will nervously put up their hands, and most of them will say, no, I haven't got hemorrhoids. And you have to actually explain to them that yes, everybody has hemorrhoids. Hemorrhoids are an organ. They're part of the anal canal and they serve a function. So the hemorrhoidal cushions are definitely present and you need to preserve them. So what is the function of these hemorrhoids? And they are part of your continence. So you need to consider the sphincters and the hemorrhoids as part of the same sort of continence mechanism. The internal sphincter almost functions like an elastic band, in that it's made up of cells that exert a constant amount of tension. It's able to relax, but normally it's sort of closed. Unfortunately, because the cells can't sort of wink out of existence, they do take up space. So there's always a gap left in the middle of the elastic band. What the hemorrhoids do is they provide something for that elastic band to squeeze to make a seal. And they are what seals the anus closed. So they are in actual fact an incredibly important functional part of your anatomy. And for that reason, you shouldn't just go around lopping them off left, right, and center. So question number 3, what causes hemorrhoids to prolapse? Because that is the main problem that patients have with them. And there are several theories on this. We don't really understand 100%. There is one theory that I think covers most of it. There are a couple of others that I think have been mainly disproved, and there are a few smaller ones that I'm not going to present. And there'll be quite a lot of bias as to which one I think is the real one. So the first one is venous pressure. So we know that hemorrhoids are a bag full of veins. If you have increased the pressure in the veins will distend and the hemorrhoids will fall out. However, hemorrhoids are a portocaval shunt. You have this the superior mesenteric vein, which feeds the superior hemorrhoidal vein that goes to the portal system. You have the pudendal vein, the inferior hemorrhoidal vein, so it's pudendal vein, goes to the caval system. So your hemorrhoids are a portocaval shunt, which would mean every patient with portal hypertension would have prolapsing hemorrhoids. And this is not the case. Despite what the HPB surgeons might think, you may have an increased, the grade of the hemorrhoids may be portal hypertension, but the incidence is not different from the normal population. It doesn't change. So here we go. So is there an increased incidence of prolapsing piles in patients with portal hypertension? No, there isn't. Okay, so they have exactly the same incidence, but they may have a slightly worse presentation or degree of prolapse than other patients. The second area around this is more around connective tissue damage. So the hemorrhoid, if you have a look at it, and the picture on the right-hand side of the screen is a slice through a hemorrhoid under a microscope. And what you can see is a lot of open venous cavities, that's all the spaces there, held in place by connective tissue, by dense connective tissue, by pectin and collagen and elastin fibers. Right at the base of those fibers, if you can see my marker here, there's some muscles called the Treitz muscle. Just like we have a ligament of Treitz muscle holds the fibers in place. In actual fact, what Treitz muscle is it's the longitudinal muscle of the rectum that is kind of splayed down into the hemorrhoid to hold those fibers in place. And that keeps those vessels in position. So there are a lot of mineralometalloproteins, I can never get that right, in this area, and they tend to break all of these down. So we have dealt with what is Treitz muscle. Treitz muscle is a remnant of the longitudinal muscle of the rectum that comes down. So when you do a hemorrhoidectomy, occasionally you find a chunk of smooth muscle in the specimen. Don't worry about it. It actually is just Treitz muscle that you've removed, and it doesn't really serve too much of a function. So I'm going to go back another slide here. When you have a look at the connective tissue damage theory of hemorrhoidal prolapse, what they are saying is if you tear the connective tissue that holds the veins in position, then the veins will fill up with blood and prolapse. So what I normally describe this as, if you think of a balloon inside a Checkers bag, you can blow that balloon up as much as you like, put as much pressure as you like into that balloon. It's not going to get any bigger than the bag allows it to. However, if you tear the bag, then the balloon will get bigger. And that's exactly what happens in the connective tissue damage theory of hemorrhoidal prolapse. So this is the theory that I subscribe to, and I think it is the one that makes the most sense, and it's the one that I direct most of my treatment to. Okay, so we've dealt with the Treitz muscle. The third theory is the theory of vascular dysregulation. Now, on this theory, they started to notice that when you had prolapsing hemorrhoids, you had a dilated hemorrhoidal artery feeding the top of that hemorrhoid. The theory was that if you had a dilated artery, you had increased vascular pressure, and you would have dilatation, neovascularization, and you would have a growth of that hemorrhoid and prolapse. What's not so great about this theory is that if you do a hemorrhoidectomy, that hemorrhoidal artery returns to a normal caliber. So the question with the dilated hemorrhoidal artery theory is it a cause or an effect of the prolapsing hemorrhoid? And my view of this is probably more of an effect, that when that hemorrhoid prolapses out, the artery dilates to fill up capacity. Once you remove the hemorrhoid, the capacity is not needed, the artery will close down again. It's also mainly mediated by hormones in that area of prolapse and inflammation. Once those are gone, hemorrhoidal artery comes back to normal size. So what are the symptoms of hemorrhoids? And the first thing anyone ever says is pain. Prolapsing hemorrhoids that are uncomplicated are not painful. They do not cause pain. They cause itchiness and discomfort. They cause, it's a delightful word that everyone loves using, they are moist, they prolapse, and they are usually painless, unless they complicate with thrombosis. So a thrombosed hemorrhoid, those are the ones that you usually see in your casualty in the middle of the night. They look like a great enormous bunch of grapes hanging out of someone's rectum. They're hard, they're shiny, they're very painful. Those are thrombosed hemorrhoids, they're painful. If you have a patient come to you, say my hemorrhoids are painful, you have a look at his bum, and he's got soft hemorrhoids that are sitting there, they are not the cause of his pain. They are soft, wrinkly hemorrhoids, look for something else. Usually look for a fissure that's causing the pain, because the hemorrhoids are not. So how do we classify prolapsing piles? This you guys should all know by now. Classified in grade 1, 2, 3, and 4. Grade 1 is what we used to call internal piles. They're sort of prolapse inside the anal canal and they don't come out. Grade 2, the piles will come out and they'll go back in by themselves. Grade 3, the piles come out and you have to push them back. In grade 4, hemorrhoids come out and there's no ways that they're going back. They are stuck out for good. So as a point of order, we no longer talk about internal and external piles. We talk about grade 1, 2, 3, and 4. So internal and external nomenclature is gone. There is also this group of new sorts of things called perianal veins. So perianal veins is the patient who comes to you and you'll see he has a thrombosed vein outside the anus or on the anal verge. It's not a hemorrhoidal cushion that's fallen out. It's actually a thrombosis outside the anus. It's a bit of semantics. It kind of has the same cause as hemorrhoidal veins, of hemorrhoidal thrombosis. It has the same treatment, but it's not an external thrombosed pile because it's not a pile. It's just a thrombosis in the perianal veins. Number 9, how do hemorrhoids complicate? So we've already discussed that they can thrombose, they can also bleed, and sometimes you get patches of mild necrosis on them. When you see these patches of mild necrosis, people freak out and think, oh my goodness, there's a dead patch, I've got to cut it out, I've got to do something about it. Leave it alone. There's lots of blood flow there. That necrosis will heal. Often it'll slough off, you'll have a bit of bleeding, but the hemorrhoid will heal. So when I was an undergrad, many years ago, one of the old surgeons who used to teach us, I still remember him standing in front of the class and sticking his finger up in the air and gesticulating and saying, hemorrhoids are bread and butter for the general surgeon, to the extent that this is the operation that will put your kids through St. John's. This is the operation that will buy you the new Mercedes-Benz. And that has been the approach to hemorrhoid surgery for years. And I could not disagree more. Okay. This is not a pathology that requires surgery. Surgery is part of the management. It is not the sole management. The number of times I've had surgeons phone me and say, oh, I had a patient with piles, so naturally I took him to theatre, and at that point I just shut them down, because you don't have to take them to theatre, and you manage their piles first. If you need to, then you take them to theatre. So if we were to look at those operations, there's the traditional Milligan-Morgan, the Ferguson, and the Parks. I've put the Whitehead in brackets because if I ever catch a surgeon doing a Whitehead procedure, they will be hauled in from the HPCSA. Milligan-Morgan is the one that we are normally taught. This is our usual open hemorrhoidectomy. You can take 3 piles at a time, cut the pile off, suture the hemorrhoidal artery at the top of the pile, make sure you have at least a 1 centimeters bridge of anoderm between each incision. You make sure that you taper your incision as you go in to the point where you ligate the artery. I usually have to describe this operation as going into a funnel. If you have a funnel with you're going to take a strip out of 1 centimeter out of a funnel. At the outer edge, it's going to be sort of maybe 10 degrees of that funnel. Once you're moving into it, your 1 centimeter width is going to be half the diameter of that funnel. You've got to narrow it and imagine you're cutting out like a teardrop shape as you go in. Otherwise, you will remove too much anoderm and you will cause a stricture. Ferguson's is the same as the Milligan-Morgan, except that instead of leaving it open, you stitch it closed. I'm too scared to do this operation because I think that I'm going to close sepsis inside and cause an abscess. I know that this is very popular in Germany and they do it quite a lot and they don't have very many issues with it, but it's not something that I've actually ventured into. The third one is Parks. This is quite an old procedure. This one I find quite intriguing because in this procedure, instead of you cutting the skin of the anoderm, you just make an incision of the perianal skin. You lift that skin up off the hemorrhoidal cushion. You then resect the hemorrhoidal cushion on its own. You put that skin back and you stitch it back together. Okay. So with this operation, you actually have no incisions inside the anal canal at all. Problems with this is obviously that you can devascularize that skin, and you have a hang of a lot of bleeding from those hemorrhoids as you're trying to take them out. I have not done this. I'm not too sure if there's anyone out there who is doing it, but it is quite an intriguing prospect for a painless procedure, relatively painless procedure. The Whitehead procedure, this is essentially the same as a stapled hemorrhoidopexy, except that instead of stapling the rectal mucosa together, you're stitching it. This is an old operation that is occasionally still performed by ancient surgeons and people who have a really big interest in it. It has largely been abandoned because it has a very high complication rate. Complications are things like stricture and something called a Whitehead deformity. The Whitehead deformity is named after the Whitehead operation, and that is where you have a prolapse of the posterior rectal mucosa outside of the anus after the procedure. It's not a great operation. Don't do this. Stick to something that's safe and stick to something that's routinely done. However, these are all nice big operations. They'll have nice big results and they're fairly durable. In the modern day, however, we're looking for something that's painless, that'll last a long time, that your patient doesn't have to be admitted for. So people have been coming up with a few different options. First of which is sclerotherapy, where you're going to inject something into the base of the hemorrhoid and let it scar up. Usually it's something like cyanoacrylate. These need to be very carefully placed, these injections, to make sure that you don't have any complications and cause necrosis. Low voltage phototherapy. This is the Ultroid device. It's quite fun. I've actually seen these before. The problem with this is it's a little sort of 2 prongs of metal that you place also at the base of the hemorrhoid inside the anus. And you can do it with the patient awake. What's nice about it is that they don't really feel it, except that you have your finger and this device up their bum. And what's nasty about it is that you have to spend at least 5 minutes per hemorrhoid with it in place for you to get that burn to pull everything inside. That makes it a bit of a non-option because you only have a minimum of 15 minutes with something big stuck up your bum, and most patients don't like that idea. So then we come to rubber band ligation. This is a very nice option. Can be done in the rooms, can be done in scope room, can be done in theater. Be careful with this that you only band above the dentate line where the rectum is insensate and you don't feel it. It's really only useful for some bleeding. It's not great for prolapse, and it's not great for sort of grade 3, grade 4 piles, but it does help when your main complaint is bleeding. Hemorrhoidal artery ligation and rectal anal repair. This operation stems from the arterial supply theory of hemorrhoidal prolapse, in that you take a Doppler device, ligation part of the operation. In Japan, they will do this 20 or 30 times around the anus. In South Africa, most of us will do it sort of 4 to 6 times. You then run that stitch down the anoderm and you pull the anoderm back up inside the rectum. You stop at the dentate line so you do not cause pain. PPH, this is an operation that most of you should have seen before. This involves placing a stapling device into the rectum. You very, very carefully place a stitch that just pulls the rectum, the mucosa of the rectum into the stapling device, and you just staple off the mucosa. The guy who described this, Lungo, in Italy, calls it 45 minutes of preparation for 1 minute of surgery. It is very fiddly. It sounds very elegant and neat until you actually have to do one, because you realize that everything falls into that scope and you can't see what it is that you're doing. So very fiddly. You've got to make sure that you don't catch the rectal muscle. You only catch mucosa. It's quite difficult to do. And if you place that stapler in the wrong position, you cause an obstruction or you cause other complications. Complications of this procedure range from intractable anal pain syndromes to mediastinitis and death. Most of the world has abandoned this procedure, except for a few people who do still do it. Hemorrhoid is the new kid on the block. This is hemorrhoidal artery ligation from, venous ligation by, it's not ligation, it's coiling by interventional radiology. The problem with this procedure is, it can help a bit for bleeding. It doesn't remove any of the prolapsing pile. It doesn't cause any stricturing. It doesn't cause any scarring to pull the pile back up inside. So invariably, your patient still requires surgery after this procedure. It's not a great option. Also has a lot of risks for causing necrosis of the organs around the hemorrhoids. So that's lots and lots and lots of information. We've gone from sort of these smaller procedures right up to the massive old procedures. Now, what on earth do we do with all of this, and who do we do what to? So there is some approach to what you can do. Sclerotherapy really only works for grade 1, 2, and 3. The infrared coagulation, which is sort of like the Ultroid, rubber band ligation, and you can start looking at major surgical procedures for the grades 3 and 4. This is a really nice slide with a really nice picture to show you where you can place your operations for these patients. What's unfortunate about this slide, and I did pull it directly off a presentation from another surgeon, is that the very top line, conservative approach, is not highlighted. It's put in white. But what you will notice about conservative approach is that it is applied to grade 1, grade 2, grade 3, and grade 4. So the conservative approach really is the thing that you should be doing for all hemorrhoids, and the rest of them fall from that. So what the books don't say about hemorrhoids is, what are you actually treating? So getting back to the initial discussion along the lines of hemorrhoids are bread and butter. When you decide to take a patient for surgery for a hemorrhoid, what are you actually treating? Is it a case of surgeon sees hemorrhoid, surgeon must cut hemorrhoid, because that makes no sense? Or are you actually treating the patient's complaint? The patient's complaining of prolapse, or the patient's complaining of bleeding, or the patient's complaining of sort of a moist feeling. Are there other ways we can treat that rather than cutting these things out? signal what's the cause of these hemorrhoids and what are the symptoms that you're trying to manage. So, but I think it was 2018, the American Society of Gastroenterologists published this, which was a guideline for managing hemorrhoids. It was fortunate because it's something I'd been doing for a few years before then, but it was nice to have someone actually put it down in writing. Top left, initial evaluation, have a look, see if the patient needs any help with bleeding, and then manage the patient from there. First line treatment, dietary modification, fiber, and toileting habits. So going back to our slide on how to manage hemorrhoids, this is conservative management. Dietary modification, fiber, and toileting habits should be applied to grade 1, grade 2, grade 3, and grade 4 as the first line of treatment. If that fails, then you can move on to office-based procedures, you can move on to excision, you move on to surgical hemorrhoidectomies and multimodal pain management. That follows on. But the very first thing you should do for this is treat the problem, or sorry, treat the cause, and the cause is poor toileting habits. Hemorrhoids are pushed out by straining on the loo. So we need to manage that regardless of what operation you're planning on doing, even if whether you're planning on doing surgery or not. So what do? I send my patients to YouTube and I tell them they have to watch 2 videos. The first one is Squatty Potty. I'm sure most of you guys must have seen this. It came out a while ago. If you haven't, please go online, download Squatty Potty. It gives you beautiful animations of the puborectalis sling around the rectum and the anus to show how you can go to the toilet without straining and without damaging your piles. These guys, the Squatty Potties, if you go online, they're from America. They're like $400 or $500 each. That's terribly expensive. I send my patients to Westpac. You can buy them for $50 to Westpac, or you can just put a pile of books or a box on the floor, get your feet up and straighten that puborectalis sling. Second movie that I make them watch, Moo to Poo. So Moo to Poo focuses on not straining and not closing off the perineum. What most patients don't realize is that the rectus abdominis muscle, the innervation of the rectus abdominis muscle, continues down into the pelvis and becomes the innervation of the pelvic floor. The moment your patient sits on the toilet and strains, they're closing off the rectus abdominis, they're tightening the rectus abdominis muscle, and they are closing off the pelvic outlet. So they shut down the anus and they're pushing against a closed exit. If you sit on the toilet with your feet on your Squatty Potty and you say, moo, like a cow says moo, you actually open up that pelvis and you allow them to defecate naturally. That must sound hysterical in their bathrooms in the morning, but I promise you it works. The number of patients who come back to me and say they're fine since trying this, I don't cut out many hemorrhoids. Next thing that they need to do is hydration and fiber. Okay, so most of my patients, I tell them should be on 2 to 2.5 liters of water a day. That's not easy to do. You need to measure the amount you're taking in. If you're drinking coffee, it's an extra glass of water for every cup of coffee that you drink. Now, if you're going to focus only on water, you're just going to pee it all out. So you're going to have something that will keep the water in your gut, and this is why you need fiber. So jungle oats, Ispragula husk, psyllium husk, they're the only really good sources of soluble fiber. I add that to their diet. I said again, fiber and more fiber. And then they can start looking at roughage and insoluble fibers as well to put into their diet. You've got to keep the stool soft. If you're not winning with that, then you can look at laxatives like Movicol and Laxon. Okay, so when we have complicated hemorrhoids, thrombosed, I will usually prescribe for my patients topical nitrates, laxatives, and analgesia. After an extensive discussion of these patients, I can say to them that if their hemorrhoid is less than 72 years, you can offer them a hemorrhoidectomy. However, a hemorrhoidectomy will cause them 2 weeks of pain. Whereas Ismo and Remicade, their pain will be gone within about 4 or 5 days. Most of them, in fact, almost all of them, I've had one patient opt for surgery. Most of them will opt for the conservative management of nitrates. The bottom line to this argument is all of these hemorrhoids will heal. You can leave these patients alone and feed them sweeties. They will heal. All that you are doing with this is helping them to heal a bit quicker. So the nitrates take the pressure off the veins, allow you to resorb that clot quicker, and they heal a bit faster. That's all you're doing. If you're going to cut it out, you've got to make sure that you have enough analgesia afterwards that they don't rethrombose anything else. So the take-home message, and this is important, is stop operating on hemorrhoids. There is a select group of patients that you should operate on. but they are diminishing in number. Because what are the risks of surgery? Pain, stenosis, sepsis, and death. As we've seen with PPHs, there are a number of patients who have died from mediastinitis. There are patients who have passed away from bowel obstructions from these things. It's not surgery that should just be taken lightly. It's not bread and butter. Treat your patient's cause, which is squatty potty and move to poo. Don't just cut the hemorrhoid out. It's not a surgeon see, surgeon do. Actually treat the cause and think about what your patient's going through. So treat the cause, treat the problem, and stop operating hemorrhoids. Are there any questions? I see 3 in the chat. Any role for medication like Daflon in treatment? This is from Dr. Ahmed Muaz. So Daflon, if I'm correct in understanding, that is a plant extract. Sorry, slip of my tongue. It's a very strong anti-inflammatory, and they do in actual fact give some relief for thrombosed piles. There's not really very much role for management of uncomplicated piles. Flavonoids, they're flavonoids. So there's not a hang of a lot of role for them in uncomplicated piles. You need to manage the actual cause of the problem, which is how they go to the toilet. So Nishlin says we're all yetas, yes. So this actually came up in my final exam. When I was asked this question in my fellowship exam, I said there are 2 groups of patients who get hemorrhoids. The first group is yetas, which is, yes, everyone on this chat. And the yeta stands for young executive with a tight ass. And it is a scientific term. It is written up in scientific papers. You may use it in your exam. It did make the gastroenterologist blush and go red and want to leave the room. But the colorectal surgeons understood what I was talking about. And what this is young patients who are usually climbing the corporate ladder, who are jumping up and down, running around, trying to impress people who are working 20-hour days, who are so stressed out that they can't go to the toilet. They put off the urge to go to the toilet, but eventually when they get home and they have to go to the loo, they're so stressed out, they can't relax, and they're pushing against a closed sphincter. That's a yeta, and that's usually the young patients who get hemorrhoids, prolapsing piles. The other group of patients who get them are the elderly. And this is the patients where your collagen has started to degrade. As we get older, everyone's collagen is going to start to degrade. Everything starts to sag. Men, women, everyone. Your pelvic floor is no different. So things start to move around a bit differently, and patients start to strain a bit more, and they have decreased collagen, so their hemorrhoids start to come out as well. So the 2 groups of patients who develop hemorrhoids are usually either the yetas or the elderly. Khat says, thanks, agreed. Someone says, I missed this. How do we end up with mediastinitis? So PPH, if you are not careful with placing the stitch in a PPH, and you catch the muscle of the rectum, and you pull that into the stapler is not designed to staple muscle. It's not an anastomotic stapler. It's designed for mucosa. That you can end up with a leak, and that leak actually tracks retroperitoneal behind the diaphragm up into the mediastinum. It's written up in the literature. We've had one of them in the unit in which I work, and it's almost invariably fatal. It's not a very common complication, but it is one that does happen. It's written about this. So mediastinitis is a problem with PPH that, I mean, for going in to have your bum operated on and then dying of cardiac infection is a pretty big ask on a patient. I had a patient in Donald Gordon about 3 weeks ago, who'd had a staple hemorrhoidopexy, who came in with a presacral abscess. The surgeon who performed the procedure had no idea what the cause of the abscess was. Sent her across to me saying he doesn't understand spotting. And he had rectal muscle into it. Now, she at least hadn't developed mediastinitis, but she finished up with 4 operations just to drain a presacral abscess from a PPH. So PPH is not a benign procedure. It's quite difficult and fiddly to do. And it's not got much better results than doing a HELRA. So I would opt for a HELRA on that patient rather than a PPH. For thrombosed piles, what is better, evacuation or hemorrhoidectomy? So I have not opted for evacuation. So by evacuation, what you can do for thrombosed pile is you nick it with a blade and you squeeze the clot out. I don't do those for my patients for several reasons. It's intensely painful. There's a lot of bleeding which upsets them, and invariably within about 4 hours the clot is back. So if you read the literature, they'd reckon between sort of 50 to 60% of these rethrombose within 4 to 6 hours. So I don't evacuate hemorrhoids. I would opt either for hemorrhoidectomy, but most of my patients, I treat them conservatively with topical nitrates and analgesia. And obviously I tell them also how to sit on the toilet, how not to push, and mooing and things like that. So no, I don't evacuate piles. It's not a great option. For a casualty officer, it may be something that they would try, but I don't subject my patients to that. Dr. Pattinson, even in the select few that need surgery, if you don't sort the straining out first, the surgery will fail. So that's a big thrust of this presentation. You can do as many hemorrhoidectomies as you like on a patient. If you don't treat the cause, the hemorrhoids will come back. So teach your patients how to poo, teach them how to manage their diet and hydration, and they will do better. The big failing of the surgical management of hemorrhoids is it does not treat the cause. All we are doing is faffing around, cutting out bits of skin that we have no business dealing with. Treat the cause of the prolapsing hemorrhoid and your patient will do better. Dr. Van Merwe, should we be working these patients for obstructive defecation syndrome? I thought a number of patients I saw really had ODS causing hemorrhoids. So yes, there are some patients who have ODS because this is it tends to fall into the same group of patients as the elderly. Older patients who have internal prolapses and rectoceles and intraceles and obstructive defecation also will have hemorrhoids, because what happens is, the normal human nature of let's take a step back. What I normally explain to people is, how do kids deal with changes in their bodies? Kids are quite smart. They're able to adapt and work around it, and they do something different. Adults are actually kind of thick. We're a bit stupid in that what we do when something goes wrong with our bodies is we sort of just push harder, or we fight harder. And we don't take the time to try and understand what's happening. So obstructive defecation syndrome is a prime example of this, where if you can't go to the loo, all people do is they push harder and they make that obstruction worse. And yes, they do definitely push out hemorrhoids as well. Once again, that's the cause of their prolapse is multifactorial. In that case, it's both the connective tissue failure and the obstructive defecation syndrome that's causing them not to go to the toilet correctly. However, once you get them sitting in the correct position, able to move their muscles correctly, and these patients usually go for biofeedback therapy, they are not for surgery, they also do better as well, and their hemorrhoids will do better as well. I hope that answers everyone's question. Sorry, that was really roundabout and quick way of doing things. Are there any more questions? Okay, look, it's past, so I guess our time is up. Can I say thanks a lot to Nish for presenting that case? That was really interesting. I learned buckets. Thank you to ECHO and the University of New Mexico and the ECHO India team for the support. Feedback form is available in the chat. Please go and have a look and download that feedback form and fill it out. It does help us to make this better for next time. Recordings will be available on the Gash Foundation website. And many thanks to the Gash Foundation for hosting this. The next Gecko Fellows will be on Monday, the 3rd of October. And the topic is upper GI. They're talking about gastroparesis. Dr. Gaila Chinnery from Fruitaski will be running that talk. So from my side, oh crumbs, there's a couple of things. Anal dilatation for surgery role? No, don't dilate these patients. This is not a patient for dilatation. It's a completely separate topic. But can I say thank you to everyone for joining in? Thanks for all the questions, and I hope that that was worthwhile. See you again next time.